Dr. DeMaria, the editor of JACC, returns this time with Dr. Joao Lima, professor of medicine at the Johns Hopkins University School of Medicine in Baltimore, Maryland, to discuss Core 320, non-invasive CT angiography plus CT perfusion equals better diagnosis of patients with suspected coronary artery disease.
Joao, tell us what question you were specifically studying and what you hope to learn.
Tony, first, thank you for having me here. The primary hypothesis we were after relates to the fact that the paradigm has shifted. In other words, what we are looking for now in coronary artery disease is the flow-limiting lesion, as opposed to the anatomic stenosis. So our primary hypothesis in this trial was that we could identify the flow-limiting lesion by combining CT angiography with CT perfusion, and we hypothesized that that would correlate with the same flow-limiting lesion being viewed by invasive angiography combined with SPECT. So when I say combined, I mean a lesion with a defect in the downstream of that artery. So that was the primary hypothesis.
So CTA was anatomy compared to invasive coronary angiography, and CT perfusion was the perfusion study relative to SPECT.
Correct. This is exactly the data set.
Okay. And was there something unique about the 320 CTA, or could you do it with 64?
The very convenient thing about the 320 CTA or the 320 technology is that you could do the CTA and the CTP for a very low radiation price, because it's just one revolution. And also for the CT perfusion, there are some advantages because you are not doing helical imaging, so you're not imaging pieces of the myocardium at different time points. So you're taking a shot of the contrast when it's perfusing the myocardium and doing a snapshot at one instantaneous moment. So if you're aiming at calculating perfusion, calculating quantitative perfusion, which we didn't do here, the 320 is a big advantage in that regard. You don't have to adjust for the timing of helical.
Yes, but in fact, you did two separate injections in this protocol, if I'm not mistaken.
Correct. We did one for the CTA, and then 10 minutes later, start adenosine, and we did another one for the CTP.
Yes, and so what was the total radiation dose here?
The total radiation dose was 9.32 millisieverts, and the SPECT was 9.75.
Give us the results.
When you take the entire sample of the 381 participants, and here we are including people who had known PCI in the past, known MI in the past, for these individuals, the area under the curve was 0.87, and there was a 6-point increment. So from 0.81, if you do only the CTA, to 0.87. But if you now do only the patients without history of known CAD, one could argue, and several of us in the Core 320 group have argued that that's the population that matters. The area under the curve for that group, patients without known CAD, the area under the curve was 0.93, and in those patients, if you take, for example, a sum stress score of 4, you consider a study positive, the sensitivity was 80%, the specificity was 80%, and the negative predictor value was still 92%. In other words, one could confidently rule out the possibility of a flow-limiting stenosis in that group.
Extraordinary results. Now, you're talking about patients in whom there was both a lesion by invasive coronary angiography and evidence of ischemia in that distribution by SPECT, and that was the endpoint. Now, I'm just thinking it must have been a bit of a nightmare to analyze these data, because you could have some people with lesions but no ischemia, or ischemia and no lesion, or ischemia and a lesion but not in the same vascular bed. How did you deal with that?
at least 6 months of solid development, almost a year to implement this, because we implement this algorithm and actually made it digital so that other people will be able to use. If you, in the future, want to use the Core 320 matching system, it will be public and available. But that was the big challenge, because actually everybody has a relationship of what should be related to, which vessel should be related to territory. The question is, when you come to the real world, the relationships are not exactly what we thought in our mind. So we had to develop a system and then make it digital, an algorithm really, because the two teams use the same system independently, the gold standard team and the CT team. And we didn't talk to each other anymore once we had developed that algorithm.
That makes the results even more impressive. Extraordinary AUCs, because essentially it's per vessel, since you had to have the vessel and the spec match up. This brings up the whole issue of how does one define a hemodynamically significant lesion, and should we be doing FFR? All the buzz here is about FFR with the FAME trial and de facto trial, and that brings up the question of non-invasively using some kind of hydrodynamic algorithm, computerized algorithm, to derive from ordinary CTA the severity of a lesion. What are your comments about that?
Tony, the theoretical concept behind or underlying this is fascinating, and it's based on hydraulics, and it should work if we had enough information on the boundaries to feed the system. So the devil is always on the details. The de facto study was shown in this meeting to have results that were not really satisfactory in the sense that can be applied clinically at this point. But the concept is very good, and one day when we have enough spatial resolution and enough information to put in the model that is needed, I think those calculations are going to be not only feasible, but would be able to be done in a timely fashion to orient clinical decision making. Until that time, I think perfusion has been tested by us. We know what perfusion defects are. They have prognostic value, and that's why we pursued this road, because if we take, for example, patients that were revascularized. So now let's move the gold standard to revascularization at 30 days. If we take patients who were revascularized at 30 days, the combination of invasive angiography with SPECT had an area under the curve of 0.81 in terms of defining which patients were revascularized at 30 days. It's not perfect because a lot of other considerations go into the decision of revascularizing somebody, but the combination of CTA and CTP was 0.79 and it was not statistically significant. So we think that non-invasively we can identify people who are going to end up needing revascularization, and yes, it is possible that in the future we would have better technology, but we thought that we ought to move to that paradigm earlier with the tools we have.
You indicated that actually based on the CTA alone, you could have eliminated the need for a perfusion study in about 50% of the patients. You also talked about the fact that with 320 and maybe with some refinements that this may be possible with a single injection. Where do you think this is going, and are you using this now clinically, or is this still investigational?
This is still investigation at Hopkins. We are actually having an IRB proposal right now to apply it clinically. So we want to move this to the emergency room. We want to move it to the real world. We have access, fortunately, to this very sophisticated technology that we would like to use it. But where do I see things going? I see things going to the direction where some pretest probability will be made on the clinician's mind as to whether she or he will need perfusion, or if the CTA at rest is likely to be the answer. For example, age, the likelihood of the coronaries being calcified. One could construct an algorithm to say, well, on this person, we are going to start with CTA at rest, and there is a 90% chance that we are going to get the answer. On that other person here, because in my practice I see a lot of sick people who had PCI and have high calcium scores, I'm going to start with perfusion, do just one shot with perfusion, and then get the answer that way. I think that that's the way things are going to go.
Well, very exciting, very encouraging results. We'll sure keep our eyes on this. Thanks very much for being with us.
Thank you.